The term proning has become common in journal articles and YouTube videos about the in-hospital ventilation of patients with COVID-19 disease, because proning, and in particular awake proning, is becoming a familiar part of treatment protocols for COVID-19. In this video, we will dive into a consideration of its origin and application. Practiced for decades in the US, proning, placing patients in respiratory distress on their stomachs in intensive care, began to enter common use with the onset of the COVID pandemic in March 2020. Lying face down is known as proning, which is a medically accepted position to improve comfort and oxygenation. The evidence for proning's efficacy in COVID-19 is no longer anecdotal. Recently, proning has been the subject of well-designed studies appearing in the New England Journal of Medicine and the Annals of Thoracic Surgery. The latter, reviewed in this update, was conducted by researchers at Penn Medicine and the University of Michigan Medical School before the COVID-19 pandemic to find strategies to increase prone positioning for severe acute respiratory distress syndrome in ICU patients. Why prone a patient? Physical position affects the distribution and volume of air in the lungs and can have direct effects on the expansion or collapse of the delicate alveoli that permit the exchange of oxygen and carbon dioxide in the blood. It has long been known that the supine position, lying on the back, can be detrimental to underlying pulmonary function, particularly for patients on mechanical ventilation. Like many in-hospital procedures, mechanical ventilation is typically administered in the supine position. In the 1970s, clinicians began investigating the potential of placing patients on their stomachs to treat acute respiratory distress syndrome, commonly known as ARDS. ARDS is a condition defined by diffuse bilateral alveolar damage and a severe mismatch between ventilation, the transfer of oxygen into and out of the alveoli during respiration, and perfusion, the flow of blood to the alveolar capillaries. Ventilation mismatch results in elevated levels of carbon dioxide in the blood and oxygen deficiency, hypoxia. Hypoxia manifests as low oxygen saturation and cyanosis, a blue discoloration of the skin. ARDS is a cause of death in patients with COVID-19. Why is the supine position an issue for hospitalized patients on ventilation? In the supine position, the lungs are compressed by gravity and other forces, including the internal organs. This position can cause hyperinflation of alveoli in the ventral lung while causing alveolar collapse in the dorsal part of the lung. Gravity complicates things by pushing blood downward toward the poorly oxygenated alveoli in the posterior lung, creating a ventilation mismatch. This mismatch is thought to drive rapid deterioration of patients with ARDS and other conditions that compromise breathing. Can proning be used in non-ventilated patients? Subsequent to studies in ventilated ARDS patients, clinicians discovered that proning may be beneficial in non-intubated, non-ventilated patients, a practice of great potential benefit in COVID-19 disease, where intubation places healthcare professionals at greatly increased risk of infection. A number of reports from the US, China, France, and Italy, including case series and retrospective analysis, have recently appeared to support the use of monitored awake proning as a method of redressing COVID-associated ARDS, while avoiding or forestalling intubation and ventilation. Proning may help avoid mechanical ventilation and intubation in patients with COVID-19. Averting the need for intubation and ICU care is among the objectives for proning in COVID-19 patients. All intubations in ICU, where patients are on mechanical ventilation, place providers at increased risk for infection by increasing the presence of infectious particles in the air. Awake proning has been shown in a consecutive series from New York City to successfully avoid intubation in 64% of hospitalized COVID-positive patients. The indications for proning include vital sign and hemodynamic stability, an oxygen saturation level of 92% on supplemental oxygen, and a conscious, oriented, and responsive patient able to move in and out of the prone position with minimal or no assistance. Patients are in a negative pressure room, closely monitored, including telemetry and appropriate nursing ratios, and re-evaluated at regular intervals. Padding is provided to alleviate pressure point injuries. If the patient cannot tolerate the prone position or has worsening hypoxia, work of breathing, or tachycardia, the patient is returned to the supine position and their head of bed elevated. At this point, it is likely that intubation and mechanical ventilation will be necessary. In late 2020, a task force comprised of researchers from 5 divisions and departments at Penn Medicine and the Division of Pulmonary and Critical Care at the University of Michigan developed a series of specific implementation strategies to encourage proning, including educational outreach, learning collaborative, clinical protocol, prone positioning team, and automated alerting, and introduced them at Penn Medicine, where they were rapidly implemented. Today, the majority of Penn Medicine's hospitals have created prone positioning teams, whose members provide consultation regarding eligibility for prone positioning, as well as staffing and expertise. To safely implement prone positioning in sites with little prior experience or inadequate staffing.